Welcome, friends. This is Dr. Jaitly, your cardiologist, on your favorite website, MuniMeterHealth.com. That's right. We are the website which is dedicated to teaching you, both to the medical fraternity as well as to the patients at large, the general masses, the medical education, as well as offering patient education in order to improve the clinical outcomes. And that's our chief goal here. We certainly want to be only talking about cardiology for now, and so without any further ado, like I always say, let's delve into the subject matter. Today we're going to be talking about the different rhythms in ECG, if you will. And there are certain rhythms I think one commonly comes across, and specifically for the medical students, the residents and fellows, and I think it's important that we tend to brush up a little bit. Now, for instance, here we have a normal sinus rhythm. What? A P, you have a Q, you have an R, and you have an S, and then a T. And sometimes you may see also a small U wave if the heart rate is very slow, like heart rate 40, 50, you can see that. Sometimes in low potassium areas also one can see that. So those are the two common causes of U waves, is just in case if they ask you on the boards: bradycardia and hypokalemia, just so that you know U waves will be present. Now, commonly, atrial fibrillation, as you know, is a fairly common arrhythmia, and specifically so as the age progresses, every decade will add more atrial fibrillations to the population. So atrial fibrillation implies that the heart rate is now beating about roughly 250 to 300 times a minute, mostly in the atrial regions, because that's where the impulses are generated. Now, atrial fibrillation normally originates from the pulmonary veins, which are situated right in the left atrial area, and there are some anomalous cells which have that atomicity, and they tend to be more involved right at the mouths of the pulmonary veins, and that has been recently shown in about 10-15 years, I would say, and invariably occurs when the left atrial pressures are high for any reasons. Okay, so atrial fibrillation occurs. As a result, now you have beats which are going at about roughly, say, 300 or more times a minute, and all these beats are coming down and eventually hit the AV node. Now, AV node has its inherent property of delayed conduction, one, and two, it has its own refractory period. So as a result, only few beats will traverse this section of the heart. That means the ventricles or the septum, the interventricular septum area, which is now you have the bundle of His and of course the Purkinje fibers as the impulses traverse back into the ventricles and ascend up. So what will happen is now you'll have beats, about 300 beats, which are arriving at the AV node, but as a result, only say a handful of them, like 75 to 80, shall traverse the interventricular septum. As a result, your ventricular rate is only about 70 to 80, because that's exactly what you'll feel as a pulse distally. The heart rate also, which is really you feel, is only because of the valves which are contracting irregular, which are closing or opening irregularly, will determine the heart rate also. So your heart rate or your ventricular rate will be about 70 to 80, because those are the number of beats that are traversing the ventricles, because the ventricles are the one which actually produce the pulse. So remember, the left ventricle, when it sends out the blood up the aorta, it'll give a pulse, and that pulse is only felt distally if the ventricles beat about 70 to 80 times a minute, and therefore the pulse will also be that. Now, we know the pulse will be irregular. We know the volume will be variable. Why? Because the RR interval is now different. Now, for instance, here we have the P waves. You'll have the flutter wave. The fibrillar waves. These are fibrillar waves that are occurring, and the fibrillar waves are plenty. They're about like 300 times a minute, and then you have a ventricular response. Then you have again fibrillar waves, and then you have a ventricular response. So you see the RR interval is not the same as here, and it's variable. And therefore, the volume of the pulse will also be variable. You have a pulse rate will be irregular also, so that'll be variable as well. Let's go to atrial flutter. Atrial flutter has roughly the rate of about 300 per minute, say approximately, but then it has its capability of doing about 2-to-1 or 4-to-1 AV block conductions. So when you have a 2-to-1 conduction, you'll see that about the atria will beat about 300 times a minute, and then you have ventricles which will beat about 150 times a minute, being a 2-to-1. So in other words, you will have for every two atrial flutter waves, these are flutter waves if you will, there will be an R response, and there will be two flutter waves in between, and then you'll have an R response. So that's an AV conduction with a 2-to-1 AV block. But if you have a 4-to-1 AV conduction, you will have roughly, again, the atrial rate being 300 as constant, taking that into account. Here the ventricular rate will be about 75, which will be determined by the 4-to-1. So in other words, you'll have 1, 2, 3, and a fourth will be conducted as an R. Again, you'll have 4, 1, 2, 3, 4, and then a conduction here. So as a result, the RR interval will be about 75, if you will, but the flutter waves you can actually map out. They look more like sawtooth type as opposed to the fibrillar waves, which are not even seen sometimes. You'll just see probably these are fibrillar waves, but the flutter waves in general, they have a regular rate. So you will see that they will be more like sawtooth type of nature. In other words, like you have a chain, a sawtooth chain, you will see those sawtooth type of appearance, and specifically in the inferior leads, namely the 2, the 3, and the AVF leads in the EKG will show that. And of course, V1 will be very, very prominent as well. So that's where you'll see these flutter waves very, very easily. Okay, now SVT is the next common one, which is also of two types. One arising because of atomicity or re-entrant mechanism within the atria. It's called the atrial tachycardia, and the ones which are arising at the AV nodal junction, and that's the AV nodal tachycardia. Now this is more common, obviously. So here the P waves tend to be buried within the RR complexes, and the heart rate is roughly about 150 to 175. So this is again a supraventricular tachycardia, and I think I've dealt with this more in detail in my SVT video, if you will, and you can refer to, just print MuniMeterHealth and then space and then supraventricular tachycardia, and that'll guide you to my playlist of supraventricular tachycardia as general. Now more in detail. Now VPCs, they could be isolated, they could be in bigeminy, that means every other beat, trigeminy every third beat, and quadrigeminy, if you will, every fourth beat. So there will be a normal beat followed by a VPC right here. You see that that's a VPC, and that's in the opposite direction, if you will. The axis is in the opposite direction. The P wave is somewhere buried within the QRS sometimes, followed by a compensatory pause, and this is your compensatory pause. And the compensatory pause included with the entire QRS complex of the preceding normal sinus rhythm will amount to 2x of the normal RR interval. So being this R interval and this RR interval, this being the x, for instance, if this distance is Ix, this will be 2x. Why? Because you have a compensatory pause after the VPC, whereas here there was no VPC. It was a normal beat and a normal beat. Get it? Okay, so 2x. And this is only when you have a compensatory pause. Sometimes the VPCs could be interpolated, we call them, and then you don't have a compensatory pause, we call it a non-compensatory pause. But in general, when you have a compensatory pause where a VPC is followed by a pause here, all of that will amount to 2x as the distance between an R and this R dash, for instance. Okay, bigeminy implies every other beat, so that means there's a normal beat and then a VPC, and normal beat and a VPC. A trigeminy implies normal VPC, normal VPC. Quadrigeminy will be normal VPC, and then a normal VPC. That means it's a quarter. Every fourth beat here will be a VPC. Ventricular tachycardia normally is very, very hemodynamically unstable, obviously, because the rates are about 250 to 300. Here the blood pressure is extremely low, and I think I've dealt with the VTACs on a special video, but just so that you know, I'm doing it quickly for the medical students. Here the rate is pretty regular, and the RRs can be mapped, if you will, and the rates can be checked. But it's a regular rate, obviously, and must be immediately attended by cardioversion. Normally you give about 50 to 75 joules, and that should suffice, and immediately put this patient back into normal sinus rhythm after you apply the joules here. Now, ventricular fibrillation, where the waves cannot even be discerned on an EKG, and basically the EKG is going like in this direction. It's almost like a near-death episode. Here, this is an emergency, obviously, and therefore defibrillation will have to be done. And here you apply at least 300 joules or over, and sometimes you may end up repeating twice or 3 times, depending upon the response here. And of course, so that's you're calling for a cardiac arrest team immediately. That's an emergency here. So in a nutshell, you've learned about atrial fibrillation, atrial flutter, SVT, VPCs, and of course normal beats. I think we have already talked about, where the normal complex looks like this. But in general, most of these arrhythmias are arising from the supraventricular area. That means the atria, and of course the VT, VTAC, and VF are arising from this area, which is the ventricles here. Okay, and again, our goal at MuniMeterHealth.com is to enhance the medical education and the patient education at large, so we can improve the clinical outcomes tremendously here, and that has been clearly shown worldwide, and that's our major goal. Again, once again, this is not a substitute to your syllabus. I advise to the medical students, it may be used as a supplement if you like, and then of course it is not in medical advice to the physicians or to the patients. So again, this is only for educational purposes. We are doing these small little video vignettes, and that's our major goal at MuniMeterHealth. Once again, thank you so much. This is Dr. Jaitly. So long. We'll see you again at the next video vignette. Bye.